Thank you, Rashmi, and thank you everybody who's traveled from really all across the world for this meeting. It's always really exciting and invigorating to hear hear from so many patients and parents, as well as researchers and physicians all around the world. So. It's my great pleasure, though, to introduce my friend and colleague, Masaki Shimizu, for giving our keynote speaker this evening, who's traveling to us from Japan. He's an associate professor at the Institute for Science in Tokyo. He did his clinical and his PhD training at Kanazawa in Japan, where he's focused his work on systemic JIA, macrophage activation syndrome, and in particular is really one of the pioneers for understanding the unique role of IL-18 in this condition. He has been thinking about this for over 15 years. I first came across his work when I was a fellow, when I was writing my first review on this with Alexei, and as we were outlining this, and he says, "Grant, you should really think about IL-18. There's really interesting things happening on IL-18 from Japan." And that's when I first began reading his work. So, and it's really begun to influence how we think about this as a biomarker for the disease, but really something that contributes to the whole disease spectrum that we see. So it's my great pleasure to introduce him and welcome him to give our keynote speaker this evening.
Thank you for kind introduce, Grant. Good evening, everyone. I'm Masaki Shimizu from Institute of Science Tokyo, and it is a great honor to be here and to present my research here. So the title of my talk is clinical significance of serum IL-18 levels for the diagnosis and monitoring of disease activity in systemic JIA and MAS. Okay, systemic JIA is a systemic inflammatory disorder of unknown etiology and is characterized by arthritis and systemic features including spiking fever, skin rash, generalized lymphadenopathy, hepatosplenomegaly, and serositis. IL-1 beta, IL-6, and IL-18 are key cytokines in the pathogenesis of systemic JIA. These cytokines initiate the inflammatory cascade through their effects on the vascular endothelial cells, hypothalamus, liver, bone marrow, and synovial joints, and then drive systemic and joint inflammation. Macrophage activation syndrome MAS is a life-threatening complication of SJIA that occurs in about 5 to 8% of patients. MAS is clinically characterized by continuous fever, hepatosplenomegaly, altered liver function, lymphadenopathy, coagulopathy, profound depression of all three blood cell lines, CNS dysfunction, and phagocytosis of hematopoietic cells by macrophages in bone marrow examination. The hallmark of MAS is uncontrolled immune response involving continual activation and expansion of T lymphocytes and macrophages, resulting in marked hypercytokinemia, namely cytokine storm. The diagnosis of SJIA is based on the combination of clinical symptoms and laboratory findings. So currently, there is no reliable biomarker for the diagnosis of SJIA. Therefore, it is sometimes challenging to differentiate SJIA from other inflammatory diseases. As you know, Kawasaki disease is much more common in Japan. So we often have the diagnostic dilemma, SJIA or Kawasaki disease, because clinical manifestation of SJIA and KD are overlapping, as shown in slide. So this slide shows the clinical course of a patient of SJIA misdiagnosed with Kawasaki disease. SJI patients misdiagnosed with Kawasaki disease often show severe clinical courses complicated with MAS, like this patient. So this patient required many times of plasma exchanges. So from these experiences, I have the first question: what is a useful biomarker for the diagnosis of SJIA? So to answer this question, we measured serum cytokine levels in patients with SJIA. At first, we tried to detect serum IL-1 beta. However, IL-1 beta was not detected in most patients with SJIA. This result was consistent with the previous study from Italian group. So next, serum IL-6 and soluble TNF receptor type 2. This receptor reflects TNF-alpha production and much more stable in serum. Levels were significantly elevated in patients with SJIA. However, as shown in this slide, these levels were not useful for the differentiation between SJIA and Kawasaki disease. So next, we measured serum IL-18 levels. Serum IL-18 levels were massively elevated in patients with SJIA and was useful for the differentiation between SJIA and other diseases. This slide shows the radar chart of serum cytokine levels in patients with SJIA and EB virus-associated HLH and Kawasaki disease and healthy children. As shown in this slide, SJIA shows IL-18 dominant pattern, and EBVHLH shows neopterin dominant pattern. Neopterin reflects interferon gamma production. And this is also much more stable in serum. And Kawasaki disease shows IL-6 dominant pattern. So the patterns of serum cytokine profile are characteristic in each disease and are useful for the differentiation between SJIA and other inflammatory diseases associated with MAS. So next, we determined the cutoff value of serum IL-18 levels for the differentiation between SJIA and other diseases. As shown in this slide, the cutoff value of serum IL-18 levels over 4,800 picogram per ml, this is determined by ELISA method, might be useful for the differentiation of SJIA from other diseases. Next, we evaluated the performance of the print criteria compared with the IRA criteria and determines whether serum IL-18 levels improve their diagnostic performances. So as shown in this table, the print criteria had higher sensitivity but lower specificity than the IRA criteria. With the addition of serum IL-18 levels, the sensitivity of IRA criteria and the specificity of the print criteria were improved to 1.0 and 1.0 respectively. So serum IL-18 levels could improve the diagnostic performance of the both criteria for SJIA. And the print criteria plus serum IL-18 levels could be the best diagnostic performance for SJIA. So second question is serum IL-18 level useful for the monitoring of disease activity in SJIA? As you know, there are three subtypes of disease cause in SJIA. Monophagic cause is defined as a single episode of active disease not lasting more than 24 months, followed by inactive disease and without recurrence of active disease during the follow-up period. Polycyclic cause is defined as active disease for any period of time, followed by inactive disease for any period of time, and then recurrence of active disease. Persistent cause is defined as active disease for more than 24 months duration. And this type is usually accompanied with chronic arthritis. So this slide shows the changes of serum IL-18 levels in a patient with polycyclic cause of SJIA. As you can see, serum IL-18 levels markedly rose with the development of complication of MAS. So A means acute, M means MAS, and I means inactive. But gradually reduced after this manifestation resolved. However, even a few weeks after normalization of other inflammatory markers, IL-18 levels were still well above the normal value, shown in red line. In this patient, MAS was frequently complicated in this phase with high levels of serum IL-18. So this slide shows the changes of serum IL-18 levels in each subtypes of SJIA. In monophagic patient, serum IL-18 levels decrease smoothly under 1,000 picogram per ml. And in polycyclic cause patients shows IL-18 also smoothly decrease to almost normal levels, but increase again before relapse. Red arrow shows relapse. And in persistent cause patients, serum IL-18 levels decrease at first, but stop to decrease and sustained elevated around 3,000 to 5,000 picogram per ml. So serum IL-18 levels change in agreement with the disease cause and reflect disease activity of SJIA. So this slide shows the prognosis of SJIA. As you can see, the prognosis of persistent type is much worse compared with other subtypes with systemic symptoms dominant types. So I think it seems that there are different subtypes in SJIA, chronic arthritis type and systemic type. So next, my question is, are there different subtypes of SJIA based on cytokine expression patterns? So interestingly, there are two subsets of patients with SJIA based on their serum IL-6 and IL-18 levels, IL-6 dominant and IL-18 dominant subset. As you can see in table, IL-6 dominant subset had more severe joint disease, whereas IL-18 dominant subset had a more severe systemic disease and developed MAS. So it seems that high serum IL-18 levels might be closely associated with the development of MAS. So from this result, next my question is, are serum IL-18 levels useful for the prediction and diagnosis of MAS? So to determine clinical significance of serum IL-18 levels as a parameter to predict MAS development, we compared serum IL-18 levels in patients with active disease who later developed mass positive, and those who did not mass negative. Serum IL-18 levels in mass positive patients were significantly higher than in mass negative patients. The ROC curve analysis indicated that the cutoff for serum IL-18 levels to predict mass development was 47,750 picogram per ml with a sensitivity of 86.7% and a specificity of 70.5%. In contrast, unexpectedly, there was no significant difference in serum IL-18 levels in mass positive patients, whether measured before or during mass. So serum IL-18 levels might not be useful for the diagnosis of mass. So next question is, what is a useful biomarker for the diagnosis of mass? So to identify the serum biomarkers for the diagnosis of mass, we employed an antibody array that simultaneously detects 174 cytokines. So we found CXCL9 shows the most significant increase following the development of mass. So next, we compared the accuracy of serum biomarkers for the diagnosis of mass. So ROC curve analysis revealed serum neopterin and as well as CXCL9 levels is a useful marker to diagnose the transition to mass from active phase of SJIA. So as you know, treatment with biologics targeting IL-1 and IL-6 show dramatic clinical effects for SJIA. And my friend Grant showed, however, these drugs can modify and mask clinical symptoms and also laboratory markers of mass, such as ferritin increase and fever, and also CRP. However, increase of serum IL-18 levels in SJIA and mass were not suppressed by tocilizumab. And this is not published yet, but increase of serum IL-18 levels in SJIA and mass were not suppressed by canakinumab too. So serum IL-18 level may be a useful biomarker of SJIA and mass, even during the treatment with IL-1 and IL-6 inhibitors. So it is sometimes challenging to make the diagnosis of mass in patients with SJIA receiving biologics. So how do you think is this episode of mass? Here I show two patients. Patient one is an 80-year-old boy with systemic JIA receiving canakinumab and in remission. So he received canakinumab on January 18th, but he visited us with fever persisting 2 days and arthralgia on February 22nd. Laboratory findings are shown in this table. Decrease of white blood cells count and platelet count, and low fibrinogen levels, and increase of FDP, GOT, LDH, ferritin were observed. Serum CRP levels are negative. So how do you think? Next patient. Patient 2 is a 5-year-old girl with SJIA receiving tocilizumab and in remission. She received tocilizumab on October 3rd, and she visited us with fever persisting 4 days on October 23rd. Laboratory findings are shown in this table. This patient also showed decrease of white blood cells count and platelet count, and low fibrinogenemia, and increase of FDPD dimer, GOT, LDH, and ferritin, and CRP was negative. So both case data resembles. How do you think is this episode MAS? So I think serum cytokine profile is useful for the diagnosis in this situation. So this is the result of serum cytokine profile in both patients. Patient 1 shows MAS-like pattern, but patient 2 did not show MAS pattern, but SJIA flare pattern. So serum cytokine profile is useful understanding what happens in the patient and also useful for the decision making. So the last part, I'd like to introduce some data about what is the role of IL-18 in the pathogenesis of MAS. So to clarify the role of IL-18 and IL-1 beta in the pathogenesis of MAS, we developed a mouse model to evaluate the role of each cytokine with toll-like receptor 9 stimulation after continuous infusion with IL-18, IL-1 beta, and a combination of both for 7 days. This slide shows clinical manifestation after CpG toll-like 9 agonist injection. So as you can see, body weight was significantly decreased in the IL-1 beta and the combination groups. Splenomegaly was observed in all groups, whereas hepatomegaly was noted in IL-18 group. And this slide shows laboratory findings. Decreased T cell numbers, CD4 and CD8, and anemia and thrombocytopenia were observed in the only combination group. So this slide shows cytokine messenger RNA expression levels in spleen, and interferon gamma, CXCL9, and IL-12A messenger RNA levels were upregulated, and IL-10 messenger RNA levels in the spleen were downregulated in the IL-18 group. And TNF-alpha, CXCL9, and IL-12 messenger RNA levels were upregulated. IL-10 messenger RNA was downregulated only in mice with extremely elevated plasma IL-18 levels, which this level is consistent with MAS patients. So this slide is the summary of our experiment, and we concluded that IL-18 and IL-1 beta have distinct roles in the pathogenesis of MAS. So dual blockade of IL-18 and IL-1 beta might be necessary to treat MAS. So in conclusion, serum IL-18 level is a useful biomarker for the diagnosis and monitoring of disease activity of SJIA. There are 2 subsets of SJIA patients with distinct clinical features based on their serum IL-6 and IL-18 levels. Serum IL-18 level is useful for the prediction of the development of MAS. Serum cytokine profile, including IL-18 and maybe CXCL9, is useful for understanding the pathology in patients with SJIA, in particular in patients receiving biologics. IL-18 and IL-1 beta have distinct roles in the pathogenesis of MAS. Dual blockade of IL-18 and IL-1 beta might be necessary to treat MAS. Okay, I acknowledge my friends in Kanagawa University and the Institute of Science Tokyo and our collaborators in Japan. And at last, I'd like to say thank you to the people of SJIA Foundation for very kind helps and warm support. Thank you for your attention.
Wonderful talk, thank you. I'm just curious, what have you observed with these levels when patients are getting infections, and how good are these of differentiating a patient with infection and patient with infection who also gets MAS?
So you mean how we differentiate viral infection and mass? Your question means how we can differentiate viral infection and mass? No? Infection? Okay. Yes.
Yeah, so I think a challenge, of course, is when these patients come in with fevers and other symptoms, and whether it's an infection or is it an infection triggering MAS, and if these cytokine panels are good at differentiating those.
Yes, that's right. It's important question. So it's very difficult. And in my institute, we use viral PCR panels for the detection of viral infection too. So we differentiate viral infection using the PCR kit. It's difficult, I think.
Yeah, so thank you for the excellent talk. So my question is again a bit in a more broader aspect, as my colleague has asked. Not only viral infections. I come from India, and I'm in AIMS New Delhi, and in Indian setting there is again, and as we all know that MAS is often triggered by lots of infections, including viral, bacterial, anything. So what is the diagnostic or specific accuracy of IL-18 differentiating these two is one of the major concern, because often we struggle with what's the right agent, whether we should start IV methylprednisolone at this point in time or should we start antibiotic. That's a real problem in our setting. So what's its value in that context, number one? And because we have seen that even ferritin, which we assume that values more than 10,000 is very specific for systemic GIA, but at the same time we know that very high values you observe in infections like dengue particularly, where we see ferritin rising up to maybe more than 30,000, 40,000 as well.
It might depend on the viral infection, but I think in patients with only viral infection, serum IL-18 levels increase mildly. So I think massive increase of IL-18 is only seen in patients with SJIA, and also today I cannot see you, but in some diseases such as NLRC4 gain of function and GAP deficiency, and also Papa syndrome, and also in some cases of familial Mediterranean fever, but with exon 10 mutation. But in FMM patients, serum IL-18 levels shows in maximum 10,000 picogram per ml. So I think we can differentiate FMF and SJIA.
That was amazing. Thank you. I'm going to ask you, and you brought it up. I don't know the answer. I don't know the good. So you just mentioned PSMPIP1. They have very high IL-18 levels. They never, in my experience, get MAS. Why do you think that might be?
I think it's a very difficult question, and I'd like to ask you too. But I have no data I have no data for free IL-18 levels, but free IL-18 levels is also in
Yeah, they're
increase in
up.
Papa syndrome.
Do you want to talk to the people for the debate now?
Oh, okay. Well, let's give
Thank you
Dr.
so much.
Shimizu-
Thank you.